Hi everyone. I'm Bree or Brianna, and I'm one of the fifth years currently at Eastern Health. I'm also on the MUPPITS committee, and today I'll be taking you through haematology and oncology for pediatrics. Um, any questions that you have, please feel free if you're at Eastern to just hunt me down in the corridors, or to also you can also email me. You can also message me on Facebook or Messenger, whatever is more convenient. I've also left my email there in the bottom right corner. For today's lecture or revision lecture, I've tried to cover everything in sufficient detail, but also I've included some gaps and some conditions that aren't necessarily on the matrix, but might come up on exams and is just good for general pediatric knowledge or um, hematological knowledge as well. But I'll definitely be highlighting what's important and what's key, and what definitely to memorize for your upcoming exams as well. Perfect. All right. So today, this is what we're going to be going through. We'll be covering anemias and thalassemia first, then ITP, TTP, HUS, and HSP. Then we'll cover some bleeding disorders, some hematological malignancies, mainly ALL, given that's your main pediatric blood cancer, and then some other pediatric oncology that's not necessarily heme specific. Perfect. I might just turn my camera off and we'll get started. Okay. Anemias and thalassemia. So the most important condition, or the most biggest R1 condition, is iron deficiency anemia. So iron deficiency anemia is when we have a low hemoglobin and a serum ferritin of under 20 typically. And it's the most common cause of anemia, most common in premenopausal women, infants, and adolescents. It's our most common cause of hypochromic microcytic anemia. So microcytic referring to the size of our red blood cells, and hypochromic referring to the color, so a lighter shade of red. And remembering that our red blood cells are normally made through hemopoiesis, which needs iron, vitamin B12, and folate. And it's this negative feedback cycle that normally regulates the amount of red blood cells and how much red blood cells are produced. So, in terms of the etiology for infants, typically it's due to nutritional disorders. So, maybe they're not taking in enough iron rich foods. Because they're growing, they have a greater iron demand, that needs to be accounted for. So that's why taking a feeding history is really important, especially when we ask about a child whether they're being breastfed or bottle fed. It can be a mix, so that's important to elicit as well if it is. And if they're being bottle fed, you can ask the formula they're using and whether it's been fortified with iron, but most of the time it is. In children, it tends to be vegetarian or vegan diets, GIT causes, or excessive cow's milk consumption. So our cow's milk consumption can cause iron deficiency anemia because it inhibits iron absorption in the gut. So normally infants under 12 months shouldn't be fed cow's milk at all. And if they're between 1 to 2 years old, we should normally limit to under half a litre a day of cow's milk. Anything more, and you could be inhibiting too much iron absorption in the gut. So asking parents how much, if any, that their children are taking is very important. And then sort of in our older pediatric group, our teens, menorrhagia can be another cause as well. In terms of the clinical features for iron deficiency anemia, things like fatigue, easy tiring. So we might ask at like kindergarten, are you finding that your child is getting tired really easily and not playing for the whole day, unlike the other children, or unlike previously? Good questions to ask. We might also find that kids are having difficulty concentrating, having shortness of breath, weakness, dizziness, paleness, acting a bit differently, so behavioral disturbances, and also pica. So pica are our cravings, or when the kids are eating non-nutritional foods. Often it's a textural thing. So unusual cravings can often be things like ice or soil, dirt, and normally for a psych diagnosis, it needs to be for more than a month, but I'm sure Sizen will go through that a little bit more. So our risk factor for iron deficiency, this is straight from the RCH, but for infants, children, and adolescents, they can differ, but obviously they also interact with one another as well. In infants, it's important to remember that mum's iron deficiency can also impact baby, especially in utero. prematurity or low birth weight, multiple pregnancies, breastfeeding as well. Again, that's because breastfeeding isn't fortified with iron, unlike mixes are or unlike bottle feeds are. A late or insufficient introduction of iron-rich foods, excessive cow milk consumption, or Aboriginal or Torres Strait Islander. In children and adolescents, things like vegetarian or vegan diets, gastrointestinal disorders, and other chronic blood loss. And then in adolescents, things to think about include the heavy menstrual bleeding as well and extreme athletes. In terms of our investigations, we will do an FBE and a blood smear. So we'd expect to see our microcytic anemia with a low number of reticulocytes. And remembering that those are just our precursors of red blood cells and they're still nucleated. The reason why we have a low number of them is because we're lacking iron, so we can't make as many red blood cells in the first place. On our blood smear, we'd see microcytic hypochromic cells, and we might see some pencil and some target cells as well. So those are our key buzzwords. In terms of our iron studies, normally we look for a low serum ferritin, so our stores. However, always remember that ferritin is an acute phase reactant. So if there's an infection or some sort of inflammatory process happening at the same time, ferritin can be artificially high. So in that scenario, what we would look at instead is our transferrin or our transferrin saturation. TIBC is the binding capacity of transferrin as well. And that would also give us another indicator of iron deficiency anemia. So in terms of management, we need to treat the root cause of the iron deficiency. So in infants, things we could advise are reducing cow's milk consumption and increasing foods that are fortified or rich in iron. And we can also consider a dietitian referral. In terms of pharmacological things, we can give some iron orally or via drops or an IV transfusion in sort of an older pediatric population or if it's severe. We always advise to take it with some vitamin C because that enhances GIT absorption as well. Some things to counsel about, side effects wise, constipation, black teeth staining, GI upset, black stools. To try and avoid the black teeth, some people like to brush their teeth with baking soda afterwards as per the RCH. That is an RCH recommendation that you can make as well. But how long we give the iron supplementation for is normally until the hemoglobin reaches normal range and then another 3 months after that. And then we can try to wean the iron supplementation afterwards. This is particularly important, weaning it off and not just stopping it suddenly as well, as with any medication. Our next topic is hemolytic anemias. So these are a range of conditions where there's premature destruction of red blood cells, and this can either be compensated for or uncompensated for. In terms of the causes, they can either be intrinsic or extrinsic, depending on whether the cause for destruction is within the red blood cell or outside of the red blood cell. Whilst there are a lot of different types of hemolytic anemias, some of the key ones to know in a pediatric population include hereditary spherocytosis. So that's where our red blood cells are being trapped in the spleen, causing extravascular hemolysis. And we can diagnose this mainly on blood film. There are some key blood film findings for it. Autoimmune hemolytic anemia, where there are autoantibodies causing destruction of red blood cells. G6PD deficiency. So this is where we have an enzyme that's defective. And whilst most people are asymptomatic, they can face a crisis when exposed to things like broad beans. And I think that's one of the big buzzwords is that someone has broad beans and then has an anemic episode or becomes jaundiced. That would be G6PD deficiency. Or if they're ill or exposed to medications like aspirin, that can cause a rapid anemia and jaundice. We also have different types of hemoglobinopathies, like sickle cell disease and thalassemia, which we'll go into a bit more detail later. With our autoimmune hemolytic anemia, so the second one on that list, we also have warm and cold versions of that, and that just depends on at what degrees the antibodies bind to the red blood cells to cause hemolysis. But I don't think you need to know too much about that at this stage. But it's also important to know that about the Coombs test, because if the Coombs test is positive, it suggests an autoimmune process going on. So that would be positive in autoimmune hemolytic anemia. but negative in hereditary spherocytosis and G6PD deficiency. Perfect. Our next topic is looking at genetic disorders affecting the structure or production of hemoglobin, and that causes structural differences. So in particular, we're going to be talking about thalassemia. So thalassemia is a problem with the synthesis of the chains, and we have alpha and beta thalassemia. So with alpha thalassemia, it's a defect on chromosome 16, and this is an autosomal recessive disease. We have 4 alpha genes, so 2 per chromosome. And depending on how many of defective genes you carry, that tells us the severity. And I've listed 1, 2, 4 there for you to have a read of, but it's not necessary that you need to know it in too much detail. Just know that 4 defective alpha genes can lead to a hydrops fatalis syndrome or alpha thalassemia major. And most of the time it's incompatible with life, just given how ineffective the red blood cells become at transporting oxygen. With alpha thalassemia, it's probably buzzworthy to know that it is more common in Southeast Asian populations, African and Indian populations as well. With beta thalassemia, this is due to defects in our beta globin gene on chromosome 11. Buzzword again is that it tends to be more in the Greek or Mediterranean populations. Similar to how alpha thalassemia has different severity, so does beta thalassemia. So we have beta thalassemia minor and major. Beta thalassemia minor, also known as thalassemia trait, is where only 1 gene is faulty. We only have 2 beta genes, unlike alpha where we had 4. Typically, patients are asymptomatic and it's mainly well tolerated unless there's a time of stress, like when the patient has an illness or if the patient's pregnant. And that's when they might have some more symptoms, some more anemia-like symptoms. Beta thalassemia major is when both genes are faulty, and that's when we have a severe microcytic anemia that needs to be managed more actively. In terms of examination findings, things that we might see are jaundice, pallor, misaligned teeth, chipmunk faces, and skull bossing. And there's a photo of frontal bossing there for you. And that's a result of extramedullary hematopoiesis. And we get a sort of protrusion of the skull, most commonly the frontal bone. So that's why it's frontal bossing. In terms of investigations for thalassemia, we would do our FBE, blood smear, iron studies, which are normal. So that's our main way of telling that it's not an iron deficiency anemia. And our hemolysis markers would be elevated. But our diagnostic marker would be our electrophoresis. In terms of management, for alpha thalassemia, we can give some folic acid supplementation. And we can consider a splenectomy in very, very specific cases. But that would sort of be a last line, because if you were to take out someone's spleen, we would have to give them preoperative vaccinations, and they would be on antibiotics a lot more. For beta thalassemia, we can give them regular blood transfusions, and we would monitor their iron very carefully as well. Perfect. The next set of conditions that we're looking at, the first one is ITP, so immune thrombocytopenic purpura. So this is an autoimmune disease characterized by an isolated rise in our platelets without any other causes, or we can't find any other cause. That's primary ITP. In secondary ITP, there's an identifiable trigger. We can categorize ITP based on timeframes, as written there. And normally we only see it in children, and most commonly it's after a viral illness or after a live vaccine. So etiology, again, primary ITP is due to autoantibodies being formed against GP2B and A. However, secondary ITP can be triggered by infections, immunodeficiencies, autoimmune disorders, live vaccinations, etc. In terms of clinical features, most of the time patients are asymptomatic, and it might be something that you just find on blood test. But we want to try and find a clear timeline. So was baby sick beforehand, or have they just had their immunizations in the last few weeks? And then signs of platelet things include bleeding, bruising, a purpuric rash, petechiae, and hemorrhagic bullae as well. And you can see a photo of purpura and petechiae there as well. In terms of investigations, we would do a few blood tests. So FBE, and that's when we would see our low platelet count. We might also see a raised white cell count if like there was a preceding viral illness, etc. Blood film, urinalysis, HIV serology, Coombs test, coagulation tests are other things that we do as well. It's important to know that ITP is a diagnosis of exclusion, so we want to rule out any malignancies or anything else as well. So we need to rule out in particular ALL and non-accidental injury. So asking about our red flags is really important. And I've put in a photo or a screenshot from the RCH about some red flags that might suggest something else is going on. In terms of treatment, we would first try to find an underlying cause and treat if possible. So that's the case if it's secondary ITP. We would stop any medications that could impair platelet function further. So NSAIDs, aspirin, contact sports, etc. And then in terms of pharmacological treatment, corticosteroids would be given. So as well as a splenectomy would be our last option. Important to note that 80% of cases will be self-limiting after 6 to 8 weeks, so not necessarily that we need to treat. But an important complication to know is intracranial hemorrhage. It's serious but particularly rare, and only really if there's a long period of severe thrombocytopenia as well. Right. TTP, thrombotic thrombocytopenic purpura. So this is where there's thrombotic microangiopathy and platelets are aggregating to occlude microvasculature. It's a clinical syndrome of microangiopathic hemolytic anemia and thrombocytopenic purpura. It's caused by ADAMTS13 deficiency or mutation, and normally what ADAMTS13 does is that it cleaves von Willebrand factor. So when we have a deficiency of it, we get increased von Willebrand's factor, which accumulates on endothelial cell surfaces, causing increased platelet adhesion and microthrombus. I think that TTP might not actually be on the matrix, but I put it in for completion's sake for all the different bleeding disorders because ITP, TTP, and HUS are often linked together and are differentials of one another. In terms of the pentad of clinical features that you get with TTP, it's fever, neurological dysfunction, so that might include things like an altered mental state, delirium, headache, dizziness, or seizures, a low platelet count, so mucosal bleeding, petechiae, purpura, microangiopathic hemolytic anemia, so symptoms like fatigue, shortness of breath, pallor, jaundice, and impaired renal function, things like oliguria, hematuria, proteinuria. In terms of investigations, we would look for urinalysis, so proteinuria and hematuria. We would do some bloods, FBE, blood films, hemolysis markers, Coombs test, which will be negative. That's to rule out alternative diagnoses, UEC, and then our special test is looking at ADAMTS13. In terms of our treatment, we can do a plasma exchange, or we can also give steroids as well. Hemolytic uremic syndrome. So this is a thrombotic microangiopathic clots that are formed, and they include arterioles and capillaries. And it's got three main features: so microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Mainly occurs in kids under 5 years old, and it's caused by a strain of, or a toxin caused by a strain of E. coli. So the Shiga-like toxin, it's caused by the O157H7 strain of E. coli, but it can also be caused by Shigella as well. In terms of clinical features, very typically it's a diarrhea illness. It's usually a bloody diarrhea for 5 to 10 days. Our typical HUS patient is a preschooler who's had diarrhea and bloody stools for the last week, and they might present with some petechiae, jaundice, and low urine output. That will typically be uh, a very typical patient and a very typical MCQ about hemolytic uremic syndrome. The triad of clinical findings is very similar to TTP, but without the neurological symptoms. And again, the main difference to it is the cause of the symptoms. So rather than being an ADAM TS13 problem, this is to do with the toxin that's being produced. In terms of investigations, bloods will do FBE, blood film, markers of hemolysis, and UECs. And then for management, we would monitor and correct fluid levels and electrolytes, so very supportive management. HSP. So HSP is an IgA vasculitis affecting children aged typically 3 to 10 years old, more likely to affect males than females, and more likely to be preceded by an ERT in about 50% of cases. The IgA immune complexes deposit in small blood vessels, and this causes an inflammatory response. In terms of that clinical presentation, you get a gravity-dependent purpuric rash, so that's why it tends to be on the buttocks and on the legs and ankles, but it can also be on the extensor surfaces of the arms in some cases. It's typically post-viral infection, so they might have some ERT signs still remaining. They might also have an arthralgia and some abdominal pain or vomiting, and this is because it increases the risk of intussusception as well. Hematuria and bloody diarrhea, scrotal edema, and subcutaneous edema are other symptoms. In terms of investigations, bedside, we will do a urinalysis to show hematuria and proteinuria. And then bloods, we will do a urine protein creatinine ratio, UEC, albumin, and then we would consider bloods to rule out ALL, ITP, etc. In terms of management, it's typically self-limiting, so about 4 weeks, but we would advise for bed rest and elevation to reduce any edema, regular Panadol, oral prednisolone to reduce any abdominal, any tummy or joint pain, and then follow up for a year as well. Hemophilia. So this is a bleeding disorder that's usually inherited in an X-linked recessive pattern. So because it's X-linked, it mainly affects males. There's different types of hemophilia, but the main 3 are A, B, and C. So hemophilia A is a deficiency of factor 8. Hemophilia B is a deficiency of factor 9, and then hemophilia C is a deficiency of factor 11. Hemophilia A is by far the most common one. It happens in about 1 out of 5,000 male births. Because factor 8 and factor 9 are both parts of the intrinsic pathway of coagulation, which I put a photo up there as well, you'd expect the APTT time to be prolonged. But we'll go into that in a second as well. In terms of clinical features, you might get things like lots of bleeding or blood noses, excessive bruising, fatigue, heavy periods, or bleeding into muscles, joints, or from the gums. Risk factors include family history, being male, and any autoimmune disorders. In terms of investigations, we do an FBE and then coagulation studies. So APTT being prolonged again is because of factor 8 and factor 9 being part of the intrinsic pathway. And if we do a mixing study, which means that we mix it with normal serum or with normal factors, this would correct the APTT. So this would help differentiate it from whether there's an enzyme or something else that's inhibiting the function of the factors versus a deficiency. We would also do plasma von Willebrand's factor as well, just to rule out von Willebrand's disease as a differential. In terms of management for hemophilia A, we can give some desmopressin, and we can also give factor 8 for prophylaxis or on demand in some cases. For hemophilia B, we can give factor 9 and antifibrinolytic agents. Because there's a bleeding risk, we advise to avoid IM injections, aspirin, and NSAID. And for any muscle or joint bleeds, they should rice the joint. So rest, ice, compress, and elevate. Von Willebrand's disease. So this is the most common inherited bleeding disorder due to either a qualitative or quantitative abnormality of VWF. Again, I think this is not in the matrix, but it's very, very common. So I thought it'd be worth including it here. It affects only 1% of the population, but of this 1%, only 0.1% are symptomatic. It's autosomal dominant, and whilst there are over 22 types of VWD, only type 3 is autosomal recessive, so most of them are autosomal dominant. In terms of von Willebrand's factor, there's three main functions of it. So the first is to bring platelets into contact with exposed subendothelium, and then that helps for platelets to aggregate, so two. And then von Willebrand factor also binds to factor 8 to prevent destruction in the circulation. So you can imagine that when there's a deficiency in it or that the factor's not working too well, some of the clinical features that we get include easy and excessive bleeding or bruising, petechiae, and epistaxis. Investigation-wise, we would do an FBE coag study, TFTs, serum protein electrophoresis, and then we can also look into the von Willebrand factor itself as well. And again, it's diagnostic if we have less than 0.3 of von Willebrand's factor. In terms of management, we would only treat it if they're actively bleeding or undergoing an invasive procedure. In terms of our pharmacological management, we would give vasopressin, which stimulates the release of VWF from endothelial cells. And we can also give a concentrate with VWF and factor 8 in it. But this will be done on a case-by-case basis. Haematological malignancies. I've included this photo here just because it details out really nicely the myeloid versus the lymphoid. This is sort of better for general knowledge or for, I guess, like year 3 knowledge, maybe some GP knowledge as well. But just the common cells that come from lymphocytes versus the cells that are more myeloid as well. But the main blood cancer in the pediatric population is ALL. And the typical question you'll get is a 2-year-old who's presented with petechiae, bruising, lymphadenopathy, bloating, and poor weight gain. And these sort of symptoms would point you in the direction of ALL. So ALL is a cancer of lymphoblastic precursor cells, and our diagnostic criteria is that you need to have 20% of lymphoid blasts in the bone marrow or a blood film. So the blasts are just non-mature white blood cells or non-mature lymphocytes. It happens most between the ages of 2 to 5. Risk factors include an advanced paternal age, the age of the child, maternal fetal loss or a history of it, family history of ALL, and genetic syndromes. In terms of etiology, there's an uncontrolled proliferation of lymphoblasts. We have increased white blood cells, but they're immature, so they don't work well. And it's also linked with the Philadelphia chromosome translocation in about 60% of cases. Clinical features are due to sort of the changes in the bone marrow composition. So we get bleeding because we're not making that many red blood cells, not many platelets to clot blood either. We get anemia, we get infections because the white blood cells that are being produced aren't very effective. We get our B symptoms, we have pancytopenia, you can have some pallor, fever and frequent infections, bleeding and bruising as well, bony pain, hepatosplenomegaly, but unlikely because acute lymphoma happens so quickly that you don't have time to develop this, but in some cases you might, and shortness of breath. And the shortness of breath can not only be because of anemia from less red blood cells, but it can also be because of thymus enlargement that happens in particular with T-cell leukemias or T-cell lymphomas as well. In terms of ALL, our investigations can include bloods, so FBE and blood films, and then our special tests. So our BMAT or our bone marrow aspirate and treponine. So that's when they take a sample of the bone marrow and they look at the composition. And if you have more than 20% of lymphoblasts, that would be suggestive of it as well. You can also do some flow cytometry, and I've listed some of the markers there that would suggest different things. Management-wise, chemotherapy has an 80% cure rate. And you can also do some bone marrow transplant or allogeneic bone marrow transplant, so using stem cells. Lymphomas. Sorry, I just realized that it should be acute lymphoblastic leukemia, not lymphoma. That's my fault. I'll change that for the post slides. Lymphomas. So Hodgkin's and non-Hodgkin's lymphoma. So lymphomas are solid tumors arising from lymphoid tissue. That's our origin point, whereas leukemia started in the bone marrow. Hodgkin's lymphoma is a malignant lymphoma, normally of B cell origin, and our characteristic feature is our Reed-Sternberg cells that look like owl's eyes. Epidemiology-wise, it's about 10% of all lymphomas that typically affects 25 to 30-year-olds or 50 to 70-year-olds. Risk factors include EBV or CMV infection, immunodeficiency, autoimmune disease, like rheumatoid arthritis. We have different classifications of Hodgkin's lymphomas, but it's not too important to know. Clinical feature-wise, we get our painless asymptomatic cervical lymphadenopathy. We can get a mediastinal mass, and that would manifest as a cough, SVC obstruction, shortness of breath, chest pain. We can get some B symptoms, pruritus and lethargy, Hell-Epstein fever. So this is an intermittent fever with periods of high temperatures for 1 or 2 weeks, and then they can be afebrile for 1 to 2 weeks, and then it sort of like fluctuates between being feverish and non-feverish and feverish and non-feverish. Another key feature is alcohol-induced pain. So this is pain in the lymph nodes after drinking alcohol. It's very specific for Hodgkin's lymphoma, but quite rare, but very buzzwordy. In terms of signs, we might have some lymph node enlargement with some hepatosplenomegaly, some weight loss, some anemia-like symptoms as well. Investigation-wise, epi blood film, so that's where we see the Reed-Sternberg cells that you can see in the photo there. We do a BMAT and a lymph node biopsy, CT scan, flow cytometry, and then management is chemo and radiation. Non-Hodgkin's lymphoma. So this is any lymphoma that doesn't have Reed-Sternberg cells. Risk factors include all these different types of infections and autoimmune diseases. There's multiple subtypes of it, but the most common one in kids is Burkitt's lymphoma, and it's associated with the T814 translocation. And on biopsy, you would see the starry sky appearance, which I've included a photo there. Management is chemotherapy. In terms of pediatric cancers that aren't hematological, nephroblastoma or Wilms tumor is the most common pediatric renal tumor. And 80% of these cases occur before the age of 5. Typically, it presents with a unilateral abdominal mass that's non-tender, hematuria, pain, and intestinal obstruction. Investigations include LFTs, UECs, ultrasound and CT abdomen to locate the renal mass, CT for any METs, and PET scanning as well. Management is surgery and chemotherapy plus or minus radiotherapy. And most patients are cured post-surgery if we catch it soon enough. I've included a photo of a CT there as well. Neuroblastoma. So this is a tumor arising from neural crest tissue of the adrenal medulla and the SNS. And it secretes catecholamine precursors. More commonly to happen before the age of 5, but in terms of our clinical features, we get B symptoms, raccoon eyes, which is quite buzzwordy for neuroblastoma. And our clinical features can change on the location because it is mostly found in the adrenal medulla. So that's why we most likely get an abdominal mass that is midline. But it can also happen thoracically or in other places as well. So where it happens will determine the symptom. In terms of investigations, things we might do include an FBE, a CT, or a PET scan, bone marrow biopsy as well, which show homo-right rosettes, which again, I've included a photo there as well for you to look at. And management, if localized, we can do surgery and chemotherapy as well. Medulloblastoma. These are highly malignant tumors from neuroectodermal tissue, and it mainly occurs up to the age of 10. So it's the most common brain tumor in kids. Again, more common in males than females, and between the ages of 3 to 8 is more common. Clinical presentation, vomiting, morning headaches, and cerebellar dysfunction, so clumsiness and coordination problems. If it spreads to the spinal cord, we start to get some back pain, difficulty walking, problems with bowel and bladder control as well. Cerebral astrocytoma is another type of pediatric brain tumor. It has very similar symptoms such as headache in the morning, nausea and vomiting, double vision and seizures. And we can classify it as high or low grade, and they have different names depending on the severity. But GBM or glioblastoma multiforme is grade 4 and the most severe, and you get this sort of butterfly appearance, which you can see in the image there as well. There's only 2 known or 2 proven etiological factors that can cause a cerebral astrocytoma, and that is ionizing radiation and a rare familial syndrome called an IDH mutation. Autoimmune disorders, asthma, and allergies are shown to be protective factors as well, but again, not crucial to know, just a fun fact. For GBM, we have a diagnostic marker, which is gliofibrillary acidic protein, or GFAP. And it's always positive in GBM, but can also be positive in other astrocytomas as well. So it's just interesting to know. In the last few slides, I've just included some buzzwords that you can put into an Anki or into some cue cards and practice. The PEDS exam is very much focused on buzzwords and a clinical focus, so a clinical picture of how a patient presents and what the diagnosis could be. So I would highly suggest having a look through those. But again, very happy for you to ask me any questions or email me any questions, and I hope this was helpful as well. So all the best, and all the best. Thank you.